Okay, so hi everybody. My name's Lisa Epp. I'm a dietitian at Mayo in Rochester. Um, I have a passion for blenderized tube feeding and capacity, but I in no way claim to know everything. So I hope to just kind of share a little bit of my experience and my knowledge with you all today. Here are my disclosures. So today we're going to look a little bit more at the literature. I know that some consumers will say, I wish I had some more kind of proof to share with my healthcare team that using blenderized tube feeding might be beneficial to me. So we're going to talk about some of the literature, some of the benefits, and then reviewing some of the options for recipes and commercial products. I'd like to start. This is kind of a new concept for me to start with saying, like, what is blenderized tube feeding? Because we've never had a standardized definition, I feel like blenderized tube feeding has been given a variety of different names. And so when I say blenderized tube feeding, what I mean is blended foods and liquids that are given via a feeding tube. Now, it may include modulars such as protein powder or may include commercial formula as well. But you can see here I've listed out some other terms that other people have used for blenderized tube feeding. Really all means the same thing. So starting with kind of why would someone consider using blenderized tube feeding? Some of these are anecdotal and some of these all are supported by evidence, but we'll talk about that in a minute. So improved bowel functions and such as improving diarrhea or improving constipation. Um, Improve the diversity of the gut microbiota or that good bacteria that's in our gut, increase patient satisfaction or caregiver satisfaction, decrease in those upper GI symptoms like gagging, retching, vomiting, cost savings or decrease healthcare utilization, decrease hospitalization, being able to accommodate family food preferences or food allergies, improve quality of life, and potentially help with volume intolerance. So, when we look at kind of this list, we do have some evidence that's emerging that really supports some of these benefits. Now, I want to say that the literature that I am focusing on is from 2010 moving forward. Even though blenderized tube feeding is not a new concept and dates back really hundreds of years, that modern day blenderized tube feeding that we're talking about really kind of reemerged around 2010. And so that's the literature that I'm focusing on for this presentation. So in 2010 to 2020, we had really just a sprinkling of articles that were in medical journals that started to show us, maybe there is some actual benefit to using blenderized feeding. And so one of the first ones was in 2011 when a study of 33 children that were given primarily baby foods or a commercial product. Had a decrease in retching, gagging, decrease in negative GI symptoms, and actually had an increase in oral intake. This study has been cited time and time again as kind of one of those initial reasons for a medical reason for using blenderized tube feeding. So then moving on a couple years later, another study came out with children who have short bowel syndrome. And so these children were mostly on an elemental formula or on TPN. And of those, 9 of the 10 children that they looked at were able to transition off of an elemental formula onto blenderized feeding and had an improvement of stooling. If any of you struggle with this disorder, having high output makes it hard to stay hydrated. And so that was kind of the first time that we saw that blended food might decrease that stool output. Moving on to 2018, a study of 20 children that were on a standard formula, and 17 of them were transitioned to a homemade blenderized formula. And this was actually a group that was given a Vitamix blender. They were given specific recipes for their own personal situation and found that there was decreased vomiting, There was increase in that good bacteria in the gut, and unanimously caregivers which were much more satisfied and would recommend using the blenderized feeding versus a commercial product. So the last study I have listed on this side is when this group was actually given a commercial blenderized formula, so a formula that was blenderized in a pouch, and were able to transition a group to this product and basically found when you look at the pediatric GI scores, which look at like reflux and vomiting and diarrhea, all of the patients that were transitioned to the pouch blenderized product had an improvement in these scores. So less nausea and vomiting, less abdominal pain, less bloating, less diarrhea. So you can kind of see there's similarities between these four studies. Number one, they're all in pediatric patients. And number two, they're relatively small sample sizes, which is pretty common for nutrition research in general, just because it is hard to kind of just look at a formula or just look at a nutrition intervention and control for everything else. You can see here in the last 3 years, though, that we've really started to see an uptake in publications related to the benefits of blenderized feeding. So in 2020, Catherine Bennett and her group put out a nice paper. I reference it a lot for different things, but I think that the part that might be appealing to consumers is this is kind of the first time where we saw where using blenderized tube feeding might save money. And so it showed that this group was in the emergency department had less hospitalization, so less healthcare utilization, which I think is as we're seeing healthcare as a customer service industry, that is really a great benefit to have decreased healthcare utilization. So each of these studies has some form of the first of the four studies I mentioned. So, like in 2022, just a month or so ago, Zhang and colleagues had a study where, again, children with short bowel syndrome had improvement in stooling, improvement in clinical outcomes with using a blenderized diet. So you can see that the literature is increasing, and just like with everything, I think COVID did slow some research down a little bit, and so I'm seeing all of the sudden now a big increase in people finishing up studies and getting things published. But again, most of these studies really are talking about children. And therefore, we can only kind of extrapolate that into adult practice. This is a nice graphic that kind of goes through some of the studies that talk about the clinical improvements with using blenderized feeding. And a couple things I want to point out in that middle column where it says type of BTF or type of formula, you can see in general, it varies. Some of it's home blends, some of it is commercial products, and sometimes it's somewhere in between. You can see that all of the studies did show an improvement in upper GI symptoms. So reflux, vomiting, gagging has decreased in all the studies. But other than that, each of the studies have kind of showed a spattering of different improvements, either with stooling or with good gut bacteria, improvement of quality of life. So I do think it's important to kind of note that regardless of the blenderized tube feeding type and regardless of the study, those upper GI symptoms were the main finding that was consistent throughout these studies here. So as far as I'm aware, this is really the only adult study that has been done. And so this was an open label pilot that was done by our group here at Mayo, where we gave a recipe that was for the individual along with a blender, and had them just go home and do home blending for 6 weeks. Really, all we were trying to do is prove that it was safe. Because to be honest, when we tried to do this back in 2015, Our institutional review board, which looks at kind of the research safety of things, wasn't sure that there was enough evidence to show that this was safe. And so that kind of really kind of sparked my interest to say is we need to make sure that there is evidence out there that using real food for people who have feeding tubes is safe to do. So what we found with this pilot is all of the patients tolerated the feeding well. None of them got any foodborne illness, so no hospitalizations for foodborne illness or infections at feeding tube sites. And everyone was able to maintain their weight appropriately, whether that have been if we wanted a little bit of weight loss that happened, or if we wanted weight maintenance that happened. And so again, this is that I'm aware of the only adult study that really shows that like blenderized feeding did go well. So, kind of to piggyback on what Rick was saying, I think that this whole movement toward blenderized feeding is really part of that patient centered care. Instead of those days where a healthcare provider would walk in the room and say, "Hey, you have a feeding tube and this is what you're going to do with it," starting that conversation where the patient is included in the decision. And I realized that for patients in the hospital, like for Rick, if when you had your stroke and if you were in the ICU, having a conversation with you about what formula you wanted to try first probably wasn't very appropriate. But starting to include patients in those decisions as soon as possible, I think is very important. And there are 130 or more formulas on the market. It seems like more are coming out daily. So in my practice, I think a great place to start is what type of diet did you have prior to needing the feeding tube? Or if it's a child, what type of diet does the family eat? And trying to mimic that. So that's a good place to kind of start. And for consumers, asking to be part of that decision right off the bat, I think is really important. This is another table that I just wanted to bring up because I think it brings in that patient-centered approach. So that article that I mentioned by Catherine Bennett and her colleagues, this is taken from that. And, they really list out when you look at home blending versus commercial blenderized product, what the pros and cons might be. And again, this is where I really like to pull in the caregiver. So for example, in this paper, they note that there might be decreased caregiver burnout if they use a commercial product. And there might be increased caregiver burnout if they use home blending. But if you've ever talked to a parent who has, or even a patient themselves who has thrown up every feeding for 3 months, that causes so much stress and burnout that sometimes they are just so happy that home blending is working. And that might feel offensive to someone to say, "Oh, you're going to be too burned out if you make home blending yourself. You should just use a commercial product instead." So, never assuming, allowing that patient interaction. The other part that I like to point out here, because I feel like this gets lost a little bit, and it was mentioned in the Real Food Blends segment before we started, was the hang time. So when we blend food from our refrigerator, it can't be at room temperature for longer than 2 hours. And if you live somewhere where it's greater than 90 degrees, it's 1 hour. And so unfortunately at this time, we don't have any evidence that supports using ice packs extends the shelf life, or freezing and thawing, or anything like that. Unfortunately, we just don't have any evidence that shows that hang time is extended past 2 hours. And so some people feel like that might be the benefit of using a commercial blenderized product, because some of those have a hang time up to 12 hours. Again, looking just at pros and cons here, but I never want to assume a pro or a con with a specific consumer situation, because everybody is different. So let's talk about practical planning. I do feel like more and more caregivers are being open to using blenderized feeding as it becomes more published and more common practice. And so if you yourself were thinking, okay, I want to get started, what would be the first step? And in my opinion, this would be the first step is talk to your primary care provider or your child's primary care provider. Have a nutrition professional available to assist you. In general, a gastrostomy tube would be preferred that would be 12 French or bigger, though some smaller French sizes do work with thinner home blends and some of the commercial blends. Have a system for monitoring just to make sure things are going well, and then having the tools needed. So, what are those tools? I love this picture because my youngest daughter is 13 now, but I remember walking into her room when she was younger and she was playing with her dolls and this was set up on the floor. And I said, "Oh, what is this?" And she's like, "Oh, I just thought it would be fun to play how you work." And I thought, "Wow, I'm surprised you really even exactly know what I do as a dietitian." So I love using this picture because yes, it reminds me that my kids do know what I do. And so the tools that are needed here, I have listed. Again, everybody finds what works for them, but in general, these are the tools that I find helpful. So having a straight connector for a low profile tube instead of a right angle connector, it just makes it so that thicker blend doesn't have to go around the corner, which can cause some clogs. O-ring syringes can be easier to push with the thicker formulas, especially with the fat content. Having large bore gravity bags instead of small bore gravity bags. A feeding pump may be used. However, the rate on the pump might need to be increased to compensate for the thicker formula. Priming definitely takes longer, and the feeding times might be inconsistent. So, what do I mean by that? Like, let's say you wanted 100 mils an hour over 1 hour. So, 100 mils at 100 mils an hour. You might actually have to increase that feeding rate to 120 mils an hour to actually make it flow at 100 mils an hour. So, that's why most of the manufacturers of feeding pumps don't recommend using home blends with their products because they're really not made for that. But I have heard that there are some companies working on a pump that would more appropriately work with thicker formulas. So I guess we'll keep our eye out for that. The reusable tube feeding pouches are another great option for a tool that can administer a home blend or a commercial blenderized product. But I really do encourage you to try to avoid using strainers and sieves. The studies kind of prior to 2010 that really kind of talked negatively, I would say, about home blending. This was a very common practice, and it did lead to micronutrient deficiencies, vitamin deficiencies, as well as weight loss, because a lot of the food that was being blended was actually thrown away from the sieve or the strainer. And so we don't want to waste that nutritional value. So I like this slide because it kind of gives an idea of, I think, what a lot of consumers feel like it's just food and water. What are people getting so worried about? And that is my philosophy as well. So it's taking what my family would normally eat for dinner, putting it in a blender and making it consistency that would go through a feeding tube. So, like you saw in the studies that we kind of briefly looked through, and this is my personal practice as well, there is so much variety out there for blenderized feeding. It's not a one size fits all. So, you might be someone who uses a standard formula and you use that every day, but you and your family went out strawberry picking and everybody's eating strawberries, and you think, huh, I'm just going to blend some of the strawberries in my standard formula because I want to partake in this event that my family is enjoying, and I want to enjoy that with them. You might use a food-based product or a commercial blenderized product, but add additional foods maybe that aren't in there. Maybe you love garden tomatoes this time of year, and that's not in your blend. And so you take your commercial product and you blend in those garden tomatoes because you want to get that food into your diet. Using just a commercial blenderized product, that's an option. Doing home blending or somewhere in between. Sometimes you might do one, sometimes you might do another. So this is an option of what I mean by using a standard formula and adding foods to it. This is also a great way to kind of get your feet wet, so to speak, with blenderized feeding, is saying, okay, my child or myself, I use a standard 1 cal per mil formula for my breakfast, and I use 2 cartons for breakfast. Well, instead of doing that, I'm kind of interested in starting some home blending. I'm going to take that 1 carton, and then instead of doing the second carton, I'm going to add a half a banana, a half a cup of oatmeal, a half a cup of blackberries, and make kind of that thicker formula for breakfast. And you can see here that that would create a breakfast meal that would be 400 calories. So in general, this is a good way to kind of get started. Some other options would be to use commercial products that are in a pouch or in a carton and add extra foods either for calories or just for personal preference. So you can see here some options of using fruit or adding some coconut oil or peanut butter to a commercial product to add additional foods in. Or you might be someone that says, you know what, I just want to make my own recipes every meal, every day, or a standard recipe. What are some options for how I would do that? And so I really look at 4 options. The first one is to use exchanges, which I'll show you here in a minute. The second one is to use a standard recipe every day. I don't love this idea because it kind of takes away a couple of the benefits that we've seen with using blenderized feeding, which is, more variety of foods might increase the variety of good bacteria in your gut. So using a standard recipe every day might take away from that, but also just the psychological benefits of using home blending related to cooking and preparing food the family is eating. Most people don't eat the same thing every day. And so using a standard recipe maybe is my least of the 4 choices here. Using my plate or family meals to make recipes, and I'll show you how to do that in a second, or using a recipe builder. For example, Complete has a free recipe builder, and I'll talk about that in a second as well. So let's look at exchanges. So this is a 500-calorie recipe using exchanges. And basically what exchanges means is that it would have a variety of foods and variety of food groups that would likely meet the micronutrient needs without having to use any kind of vitamin or mineral supplementation. So you can see here that so our group here at Mayo, we have tested this recipe using all of the foods that are listed here. But for example, I'll have people ask me, hey, instead of, pasta in here, could I use quinoa instead? And yes, once you get kind of good at blending, you can more easily swap out foods in each category. But this is a nice way to get started. You know that the recipe is going to be about 500 calories, and you know it's going to be, because of the water content of the foods, a consistency that will go through a feeding tube, no problem. This is an example of a standard recipe that we have for our hospital here. We have standard recipes at different calorie levels. And so these recipes are mostly used, honestly, with foods that are available in a hospital setting. But in general, just gives you an idea of a kind of a balanced recipe that would meet micronutrient needs and have appropriate carbohydrate and protein and fat in 1,000 calories, if that's the calorie level that you were looking for. The My Plate plan is kind of my preferred method, I would say. So on the USDA website, there's a great option where you can go and kind of click what calorie level are you looking for. And of course, it's made for people who are eating orally, but people who are putting food through a tube have those same nutrition needs. And so this is a recipe for 1,400 calories, or kind of a meal plan for 1,400 calories. So it would go through and give you an idea of like how many fruits, how many vegetables, how many grains, how much protein would be needed to kind of make it a balanced recipe. And then you can kind of write those foods if you have recipe sheets, and that can kind of help you build your recipes. That's really similar to what they have on the Complete website. And so essentially, you choose a calorie level. You choose foods from each category, like it will say, choose 3 fruits, choose 3 vegetables. The nice thing about it is next to each food, it also tells you how many milliliters that food will add to the blend. So if you have volume intolerance, you can say, okay, what adds the least amount of volume? And then it gives you at the end kind of a recipe summary that would say, okay, this recipe has this many calories, this much protein, and may be low in calcium or may be low in vitamin D, and therefore you may need a supplementation. And so it really gives you kind of a way to build recipes on your own. In general, the recipes are 1 calorie per milliliter, and they go up to 2,000 calories. So if you would need more than 2,000 calories, it is kind of built for pediatric patients, but you could definitely double or triple a recipe as well. And so it just gives you some different options for building recipes if you are interested in doing that on your own. I like this slide because one of the common kind of questions I get or just comments I get is, I have volume intolerance or my child has volume intolerance. How can I add nutrient dense foods in each category with a lot of calories and not a lot of volume? So in each category, meaning fat, dairy, fruit, vegetable, and grain, I just have some ideas here of foods that in general are low volume that have 100 calories that could be added to a blend to kind of bump up the calories without adding too much volume. So lastly, I just want to put a plug here. So Aspen, so Rick had mentioned American Society for Parenteral and Enteral Nutrition, is working currently on clinical recommendations for blenderized tube feeding. And this is expected to be published later this year, but these are some of the things that you can expect from it. And I really do think once Aspen publishes this, a lot of that reservation that some of your clinicians might have is going to be taken away because they're going to see a major society has given recommendations on how to do blenderized feeding both in the hospital and at home. And I think that's just going to be beneficial then to the consumers who are interested in doing this. So with that, I will take whatever questions Lisa wants to throw my way.
Okay, we have a couple. One is, I think, let's see. If you were to blend scrambled eggs with your formula, would the thickness help with reflux or GERD?
I think potentially yes. I will tell you, if you're going to add one food to your formula because you want to help with GERD, green beans has actually been studied to help with thickness and kind of help with weight. And so I think eggs would definitely help. But if I was looking at evidence, green beans has been used in a variety of different settings to help with reflux and stooling as well.
That's great, Lisa. Thank you. Another one is a little bit longer that one of our participants notes they have problem with small intestinal bacterial overgrowth. Mm-hmm. They've been trying different foods and have found that sometimes it makes the SIBO worse. The person says, as the motility is a little improved, I've been trying to eat or blend some foods, but have been having trouble with the intestinal bacterial overgrowth. do you have any advice for choosing foods to blend that would not irritate the overgrowth?
I think what's hard about answering a study like this is, small intestinal bacterial overgrowth is a medical thing. And so in general, our team and my philosophy is we can't use nutrition to treat a medical diagnosis. But in general, if you did not have a feeding tube and you have small bowel bacterial overgrowth, eating a wide variety of foods is the recommendation. And so you might find things that, work for you or don't work for you. But in general, there's no list of foods that you should not be having. And there's really no list of foods that you should be having. It would be a wide variety of foods. And so this is where, and actually even at Aspen this winter, they even started talking about using potentially in the future blenderized feeding in the ICU to help with bacteria in the gut.
Thanks, Lisa. Let's see, another question is comments on how wonderful your resources are, and thank you. And then the question is, what would you recommend as the best resource to share as a registered dietitian to share with fellow dietitians? And in your experience, has collagen been studied or added to any blenderized recipes?
As a registered dietitian, when I have been asked questions, and I have been asked questions like, aren't you worried about liability, or aren't you worried that, something's going to go wrong? The reference that's most helpful is the Registered Dietitian Nutritionist Guide to Homemade Blenderized Tube Feeding, which is out for a couple of years and produced by the Academy of Nutrition and Dietetics. So I feel like that is the best resource for clinicians to get started, but also to feel comfortable that yes, this is part of standard practice, that this is safe and this is okay to use. I'm not aware of collagen specifically being studied with blenderized feeding.
Thanks, Lisa. And this will be the last one today. I think there are a couple of other questions, but we're going to run out of time. But can you comment on, well, and actually, we can cover this in more detail tomorrow, but it's on, can you comment on blenderized tube feeding and NFIT? So NFIT is a new connector that we'll be talking about in more detail tomorrow when we talk about devices. But do you have a quick answer to that, Lisa?
Yeah, I'll say my quick answer is, and I think this will be shared tomorrow, but we have done some studies here with using our blenderized recipes with NFIT. And really overall, I would say we have no problems with using them. About 50% of our 2,000 patients use blenderized feeding in some capacity. We've been using NFIT for more than 2 years, and we still have 50% using blenderized tube feeding. So it's definitely possible.
Thanks, Lisa. I don't know if you're able to be on the line a little bit, but there are some other questions in the Q&A. And if you have a few minutes, if you want to try to address any of them, written, that would be wonderful. But if you can't, that's certainly understandable. I will say that we have, I think it's Lisa that has done a webinar for us in the past on blenderized tube feeding. And there are some other resources on our website too, where you may be able to get some of those questions answered. So thank you, Lisa. Really appreciate it and look forward to hearing from you again soon in the future.
Sounds good.